All right, everyone. I wanted to do a quick audio visual check. If you don't mind putting in the chat box, if you can see me, hear me, and also see my slides, go ahead and type in yes into the chat box. Awesome. Chitra, Rahana, Punita, Gretel, Ahmed, Neha, thank you all for joining. We are going to get started in just a little bit. Make sure you turn your chat box to panelists and attendees so that we can all interact together. There's going to be a live Q&A at the end, but 5 more minutes, we will get started. Make sure you take out all your distractions, and we are going to be covering psych very, very soon. All right, see you guys in a little bit. All right, everyone, we will get started in just 2 minutes. I am so excited to have each and every one of you here today. We have an international audience. Can you believe it? Over 155 people joining in right now, live. I can't wait. Please, please go ahead and say hello into the chat box. Make sure your chat box is panelists and attendees. We're going to get started in just a little bit. Just say hello. Tell me where you're from. I'd love to connect with each of you. This is going to be a great review today. All right. Well, welcome everybody. It's 10 a.m. Eastern time. Are you guys ready to get started? Can you hear me and see me? Go ahead and type in yes into the chat box. Awesome. Fausto, Nolani, Jasmine. Wow. We have so many people joining in today. Thank you guys so much. I really appreciate it. And over the next hour and 15 minutes, we are going to be going through some high yield material for your USMLE Step 1. I absolutely cannot wait. So welcome, welcome, welcome. Today we are going to be talking about key principles for NBME psychiatry questions. This is actually going to be a review that will be helpful not only for Step 1, but if you're gearing up for your psychiatry shelf or even Step 2 CK, a lot of the concepts are actually going to have great homogeny. They're going to translate back and forth between exams. For many of you, this may be your first time joining one of these webinars, and I'd like to take this opportunity to just introduce myself. Welcome. My name is Rahul. I'm currently in my last year of pediatric critical care fellowship. And over the past 7 years, I have been absolutely passionate about helping students just like you kick ass on the USMLE Step 1. My passion is to really help students with test taking strategy, productivity, and integrating content in an active recall way. And I am so humbled that you have joined me today. For all of you who are returning, welcome back, family. I can't wait to do another kick-ass webinar with you today. So just as a little bit of a background, I wanted to go through what makes HyGuru, this passion project of mine, so unique, because there are so many resources out there for your USMLE. And when I break it down, I really like to think of HyGuru as this evidence-based approach to USMLE preparation that is all contingent upon active recall, basically an integrative Anki deck and an element where you can take content across domains, biochemistry, microbiology, physiology, pharmacology, and integrate them together in an organ systems-based manner. And finally, HyGuru really focuses on thinking like the test maker. My goal is for you to have a systematic approach to test taking so that not only can you get good at the content, not only can you even get good at integrating the content, but I want you to get good at applying the content because that's what's going to ultimately help your score. So when I approach USMLE preparation individually and when I work with medical schools, I kind of focus on this triad. Now, there are many triads in medicine, but this is my USMLE triad. I like to focus on the application of content and test-taking strategy. I also like to focus on making sure you're very productive, but I want to take it one step further. I think that productivity and scheduling is one thing, but I like to tap into this element right here, which is test-taking psychology. Remember that this is such a grind. And what I want to do is I want to inspire you to be better each and every day, 1% better each and every day, so that you feel like you're preparing with purpose. Most importantly, what I've been absolutely humbled by, and we have a live stream here on Zoom, we have a live stream on YouTube, even on Facebook, is that HyGuru is a community. And I have been absolutely humbled to work with top tier medical schools in the Midwest and teach live courses. And now we are a global community thanks to the advances in electronic learning. So I am super, super pumped that we can be here together today. So many of you have seen these NBME Top Concepts webinar. And I really wanted to go into a little bit as to what inspired me to really create this webinar. As you know, there was a post on Reddit not too long ago that went through a little bit of an outline that captures the most recurring concepts from the NBME practice exams. And so I used that outline as well as some of my own expertise to put together a review. And over the past, 2-3 months, we have covered a lot of that outline. And all of that material is there for you to really prepare with. I mean, students yesterday were Instagramming me being like, hey, this evening I'm watching one of your videos. And that really humbles me. I mean, that is so awesome that each and every one of you have been really utilizing all of these organ system reviews. And today we're going to check this box off. Look at how many reviews we have done so far. I've also put all of these reviews into a YouTube playlist so you can watch them in a stepwise manner. But also, guess what? I have taken all of these lectures and absolutely for free, I have chopped them up into little bite-sized pieces with active recall questions. And I have essentially put them into one course. And that is known as the Golden Style course. It goes through all of the concepts in bite-sized pieces so that you can actually go through a solid review before your USMLE, before your NBME, before your school exams as well. So without further ado, I really appreciate you guys sticking with me through that introduction. But this is the most important question today. And that is, are you guys ready to get started? Go ahead and open up the chat box and say yes if you are ready to get started. How many of you all are ready to get started? We have so many people who are absolutely pumped. Thank you guys so much for the enthusiasm. I want to make one disclaimer. And that is that I ask for just an hour and 15 minutes of your time today. I truly do. And I would really encourage you to just cut out all your distractions, turn your cell phone off, make sure you're taking those browser tabs off, and just focus with me for this next hour and 15 minutes. I promise it's going to be well worth your time. And guess what, guys? At the end, I'm going to be doing a live question and answer covering USMLE preparation, any other questions you have. I'd be happy to have that live dialogue and Q&A with you guys. All right. So the Bollywood in me is pumped. Let's go ahead and get through the overview and start our psychiatry session today. So when it comes to psychiatry, I'm going to break it down into a couple elements. We are going to be covering mood disorders, which basically is going to focus on depression as well as mania. We're going to be pivoting and talking about many of the schizophrenia disorders, i.e. psychosis in general. We're going to be covering all of the schizoaffective, schizotypal, schizophrenia, right? There's going to also be an emphasis on the personality disorders, such as schizoid versus schizotypal. We're going to be covering eating disorders, and we're also going to be covering drugs of abuse, i.e. some of the toxicology, which you need to know. And that is where I'm going to integrate really, really high yield. I'm going to integrate a lot of the autonomic pharmacology, and that's really going to help you for your upcoming USMLE exam. So what we will first do is start with mood disorders. Now, whenever somebody says mood disorders, I want you to be thinking about depression, anxiety, as well as bipolar. These are your classic mood disorders, especially depression and bipolar. So let's go into that by first starting with a multiple choice question. A 50-year-old female presents with sad mood. She is irritable and states she feels worthless and helpless for the last 2 weeks. She just broke up with her husband a month ago, and she finds that at work, it is tough to concentrate. She has lost weight unintentionally. She did not show up to work today because she, quote, doesn't have the motivation anymore. Her vital signs are stable. What is the likely diagnosis? So real quick, I'm going to make a big deal about this, but remember, this lasted 2 weeks. The trigger was about a month ago. What do you guys think the diagnosis is? A, major depressive disorder. B, dysthymia. C, adjustment. D, normal grief. Go ahead and put that in the chat. We are warming up. I hope you guys are all going to be answering within the chat box. Seeing a lot of D's. All right. Well, the answer here is actually going to be A, major depressive disorder. Remember that this patient has a functional decline, and that functional decline, along with signs and symptoms of depression that range from worthlessness, guilt, as well as losing weight unintentionally, all of those things with the functional decline over a period of 2 weeks point to more major depressive disorder. what I want you guys to recognize, and this is a key psychiatry test-taking strategy tip, is that psychiatry questions on the USMLE can be boiled down to 3 strategic points. That is, number 1, you need to in test questions isolate functional impairment. Activities of daily living that are compromised, in this case, the patient wasn't able to show up to work, that is something that you really need to hone in on. Second thing is paying attention to the time period for diagnosis. Always look at that in the test questions. And third thing that I really want to say, and this is true for your shelf exams as well, is to think about medical causes of psychiatric disorders prior to diagnosing with a primary psych disorder. So for example, B12 disorder, B12 deficiency, hypothyroidism, Cushing syndrome, all of these are medical causes that could present with psychiatric manifestations. So examples of those medical causes, they could be thyroid, medications such as beta blockers, and nutritional deficiencies. Remember, B12 deficiency can give you a macrocytic anemia, but can also give you neuropsychiatric symptoms. So the key that I want to really emphasize is that functional decline that you will see in a lot of these test questions. So the classic mood disorders that we are going to compare and contrast for your USMLE are going to be depression and bipolar. Now, with depression, a lot of books and a lot of resources teach SIGA-CAPS, but I like Dice's gaps because I'm special like that. Dice's gaps basically gives you the diagnostic criteria for depression. And that is depressed mood, loss of interest, concentration issues, energy issues, sleep disturbances, guilt, appetite, psychomotor, slowing or agitation, and suicidal ideations. Now, many of you have seen this already, but I'm going to push you guys. And what I'm going to say is you really need to hone in on how that this is asked in the psychiatry vignettes on the USMLE. Remember that they won't be like, oh, low energy. They may say, hey, the patient is unable to do their daily tasks, or they have lost interest in something they used to like to do. And so understanding how these diagnostic criteria can be asked is going to be really important, but also capturing these diagnostic criteria relatively quickly as you read through these vignettes. Because go ahead and raise your hand and tell me that a lot of these psychiatry questions are going to have longer vignettes. Don't you agree with me? So you're going to have to really, really hone in on that element. So Dice's gaps is going to be the diagnostic criteria for depression, and one of them has to be either depressed mood or loss of interest. And I want to highlight that in red because you need to isolate that very quickly. That's a salient feature in the test question. So you need 5 of 9, and it will be present for 2 weeks, and one must be either the Dice D, the depressed mood, or anhedonia, which is the loss of interest. Now, let's pivot and let's talk a little bit about bipolar. Bipolar, I like to use dig fast. These patients are going to be super revved up. They're going to have distractibility. They're going to have irresponsibility. So maybe they're going to have purchases that are just going to be off the wall, or actions that are going to be totally out of societal norms. They're going to have grandiosity, a flight of ideas, activity increase. These patients may not sleep well, and they're going to be increasingly talkative. Now, with bipolar disorder, you need to understand that there could be some element of psychosis which accompanies bipolar disorder. And so if you look at the diagnostic criteria, you need greater than 3 of 7. Look at these odd numbers, greater than 3 of 7 for 1 week. And you need to watch out for those psychotic symptoms, which are going to be those delusions and hallucinations primarily. All right. So mood disorders, compare and contrast. Let's go ahead and practice a little bit now. A 17-year-old male presents to the adolescent clinic. He was in a car accident 2 months ago and unfortunately witnessed his mother pass away. He states that he wakes up really early and thinks about her mother often. He feels very overwhelmed and says, it's tough to go to school. When asked about his mom, he tearfully states, she was a really amazing woman. What do you think is the most likely diagnosis here? PTSD, complex bereavement disorder, normal grief, or major depressive episode? All right. A lot of people putting in the chat. And if you said normal grief, you're absolutely correct. Remember that this patient doesn't have as much functional decline, doesn't have as much of those somatic symptoms like the weight loss and some of the other issues that can come with just a major depressive disorder. It's not going to be complex bereavement disorder, because with complex bereavement disorder, you need symptoms of relative pathologic grief for about a year. And so this is just really normal grief. Now, one key thing that I will say in normal grief that the USMLE loves to go for is this element of patients wanting to join the person who has passed away. And that is distinct from being suicidal. Having those wishes to say, oh man, I wish I was with my mom in heaven, is totally different than actively having suicidal ideations. But I just want to make that small distinction because it comes up on exams often. So this slide is going to talk about teasing out grief from depression on the USMLE. Remember, key elements of normal grief are the fact that you could go through these stages of grief, which is denial, anger, bargaining, depression, and acceptance. And remember that this may be the expected roadmap, i.e. going in this order, but this can happen in any order and it can flip back and forth. And that's important for us to know. This occurs in waves. Grief, you get good and then you get bad. You get good and you get bad. There's limited functional impairment. And like I mentioned, there's a lack of suicidal ideation. What's important for us to recognize is that for grief questions, you always want to isolate that trigger. You got to understand that grief is going to be preceded by some sort of death, some sort of trauma, etc. And so then with that trigger, plus the lack of functional impairment and the fact that it's going to be getting better with time, i.e. maybe less than a year, those can all be the features of grief on your USMLE questions. So let's go ahead and talk a little bit more about depression, because remember that last criteria was suicidality. A 60-year-old man presents to the emergency department intoxicated. He was found to be near a bridge and having a firearm pointed to his head before law enforcement stopped him. His history is notable for major depressive disorder and recent hospitalization for a prior attempt at suicide. On exam, he says, "My brother died by hanging himself, and I feel worthless as well. I am alone, and life is just not worth living." What is the most important risk factor which poses the highest risk for completion of suicide in this patient? And so I went through this vignette and I kind of highlighted the key points. And one thing that I want you to recognize is that a prior attempt is one of the greatest risk factors that is associated with completion of suicide. Now, what are some other risk factors associated with suicide? Let's go through this. Psychiatric disorders such as depression, firearm possession. This can be asked as an ethics psych question on your USMLE. Which of the following risk questions do you want to ask? And that is possession of firearms. A family member passing by suicide. Remember that males complete more, whereas females attempt more. And females on the USMLE that are going to have, for example, borderline personality disorder are going to have an increased predilection for self-harm, as well as poor social support. So this vignette really highlights some of those key risk factors, and a prior attempt being one of the most important. So when we think about depression for the USMLE, yes, you have the SIGA gaps or the DICES gaps, but I want you to also look out for atypical depression, as well as depression with psychotic features. So let's go through some of the key elements of both of them. With atypical depression, in your questions, you are going to have actually increased appetite, sleeping more, and this mood reactivity. So basically what that means is that in the vignette, they'll say, hey, I'm going to maybe compliment you. You end up having the patient brighten up in mood and then maybe fall back down in depression. So understanding that atypical depression, you eat more, you sleep more, and you're a little bit more sensitive. Those are going to be those salient features. You're going to use more behavioral therapy, but you could also use MAOIs in refractory cases. Now, for psychotic features related to depression, remember that if you have depression with psychotic features, they have to go hand in hand. When you think about psychotic features and depression, watch out for DICES gaps along with those psychotic symptoms, which include delusions and hallucinations. Remember, if you have Dices, gaps, and psychotic symptoms, and then 2 weeks of just psychotic symptoms, you got to be thinking of schizoaffective disorder as well as schizophreniform. But what you need to understand here is that schizoaffective, sorry about the typo there, schizoaffective has 2 weeks of pure psychosis without any depressive symptoms. Very high yield for us to understand and integrate the difference between depression with psychotic features as well as schizoaffective disorder. We're going to review that when we talk about psychotic disorders as well. So let's go through this question. A 40-year-old male presents with feeling unhappy. He says that he has been so burnt out at work. He left his previous job as he felt like everything was a chore. His fiance states that he has little energy throughout the day. He has a history of smoking marijuana as a teenager. And when asked how long he has felt these symptoms, he says, "I don't know, doctor. It's been years." His toxicology screen is negative. What is the likely diagnosis here? Adjustment disorder, cyclothymia, avoidant personality disorder, or dysthymia? What do you think is going to be the answer here? Well, if you're thinking about this long-term depression, remember it says over years, you're going to be thinking of dysthymia. That's really important for us to recognize, is that dysthymia is kind of like Eeyore from Winnie the Pooh, right? He has a depressed affect all the time, like the rain cloud is pouring over him. That is the best way to really think about dysthymia. And remember, the key diagnostic criteria, it's depression greater than 2 years. So let's kind of go into another element of depression, and that is integrating the medical causes of depression. Now, remember that organic diseases, like how I said in the strategy portion of this, organic diseases on the USMLE can kind of present as depression. So what are those things? Well, think about substance abuse, all of those downers, alcohol, opioids, hallucinogens, beta blockers, things like hypothyroidism, sleep apnea, mononucleosis, vascular strokes, as well as even dementia. And so what's important for us to recognize is that if you have a patient who, for example, has 3 or more medications within the vignette, think about substance use and depression kind of going hand in hand. Also, if you notice that there are signs of vital signs, or if there are going to be issues with vital signs, such as bradycardia, well, maybe you're thinking that depression is more related to hypothyroidism or hypertension. Maybe it's related to sleep apnea. And then if you just have this isolated activity of daily living decline, well, just think about dementia. Because yes, dementia can have an association with depression, but Alzheimer's patients are just going to have an isolated activities of daily living decline rather than having those SIGA caps with it. There's a unique one that I do want to highlight because it shows up on exams, is the seasonal affective disorder. Remember that it is going to be worse in the months where there's not much sun, and there's this distinct carbohydrate craving in seasonal affective disorder. All right, so we covered one element of mood disorders. Now let's go into the next element, and that is talking about bipolar disorder. With bipolar disorder, let's go through the diagnostic criteria one more time. Dig fast: distractibility, irresponsibility, grandiosity, flight of ideas, activity increase, sleep deficits, and talkativeness. Dig fast. 3 out of the 7 and 1 week is key for the diagnostic criteria. Let's practice. A 30-year-old male presents to the county physician. He is brought in by police for medical examination. He was arrested last week after being found at Walmart assaulting customers. He states that he is a, quote, knight in shining armor and says that he does not need to sleep. When asked about his mood, he tells a very long story about his childhood and fascination with swords. As you can see, I put this in many elements of the past questions. Talk screen is negative. So what is the likely diagnosis? A, brief psychotic disorder. B, bipolar 1 with psychotic features. C, schizotypal. D, hypomania. We have a lot of people who are participating, which is absolutely awesome. The answer is going to be B, bipolar 1 with psychotic features. Remember that there are elements of mania in this question: talkativeness, decreased need for sleep, poor decision making, all of those in combination with those hallucinations as well as delusions. You got to understand that that's bipolar 1 with psychotic feature, and brief psychotic disorder would actually not have mania symptoms, and it would be self-resolving relatively. So when we think about the mania symptoms, we also have to understand what is hypomania. Now, with hypomania, here is a classic vignette that you may see. A 42-year-old woman presents due to fatigue, weight gain over the past month. She says that she has been struggling with depression for a long time, but things have gotten worse since her husband was diagnosed with cancer. She also says that she had previously an episode of decreased need for sleep, irritability, increased goal-directed activity, which lasted about a week. But as you can notice right here pertinently, it never significantly impaired her work or home life. And so what is the diagnosis here? This is a classic vignette for hypomania. Yes, you have mania symptoms, but not much functional impairment. And so what you have to understand is that hypomania, it isn't even a whole week. It occurs most of the day for at least 4 days. There's no psychosis. Remember, if you have psychosis, you're likely going to have bipolar 1, and there's a relative lack of activity of daily living decline. Let's go into this next question. A 40-year-old female with congestive heart failure presents with tremors. So she has a neurological symptom. She has a wobbly gait on exam. On review of medications, the physician notes a history of bipolar, well-treated on a mood stabilizer. She was started on diuretic therapy for congestive heart failure on her last visit, which was about 2 weeks ago. Which of the following drug interactions most likely contributed to her tremor? A, lithium and hydrochlorothiazide, lithium with amelioride, lithium with metoprolol, or lithium with clonidine. So when you think about this very fine tremor and the fact that the patient is on a mood stabilizer, you're going to be thinking about lithium, and you're going to be thinking about a drug interaction, specifically hydrochlorothiazide, which has a classic interaction with lithium because of its tubular effects and the fact that it reduces that clearance of lithium. That's very high yield for us to know. So let's go through lithium toxicity next as a very integrative approach. Lithium has a narrow therapeutic index, and that's a Gen Pharm tie-in. I'm going to go through that in the next slide. When we think about lithium toxicity, you want to think of thyroid issues, things like hypothyroidism, because lithium is going to end up having increased uptake by the follicular cells of the thyroid, and that's going to impair the thyroid synthesis from thyroid peroxidase. Now, there are going to be some non-specific symptoms that you can see with lithium toxicity, things like nausea, diarrhea, weight gain. You may even see signs of hypovolemia, especially if there's going to be an interaction with the diuretic, and this fine tremor that's going to be primarily isolated to the distal extremities. Now, remember that lithium use in pregnancy can cause you to have some element of cardiotoxicity. We call that Epstein's anomaly, in which you have the tricuspid leaflets kind of downwardly displaced. And so the right atrium gets big, and you have the right ventricle then essentially acting like your atria. So that's what they call the atrialization of the right ventricle. And then finally, understand that lithium can plug up those aquaporins and cause you to have nephrogenic diabetes insipidus. So let's pause right here. Let's integrate that vignette. Remember that nephrogenic diabetes insipidus, serum sodium will be up and your urine osmolarity will be down. Very high yield for us to know, and understand that lithium can deposit in the interstitium of the kidney and cause you to have a chronic interstitial nephritis. And remember that interstitial nephritides are going to be characterized by eosinophilia. It's kind of like a hypersensitivity reaction. So let's go ahead and understand a little bit more about lithium and this concept of therapeutic index. Now, therapeutic index is basically a ratio of the dose that helps you, i.e., the therapeutic effect, over the dose that kills you, i.e., the toxic effect. And so if those two lines are close together, that means that you have a very, very tight range in which you have the dose that helps you for the disease and the dose that can cause you toxicity. And so that's why drugs that have narrow therapeutic indices, clinically, we have to monitor levels very closely because we don't want those patients to be on that drug and then get the toxic side effects of the drug. So what are going to be drugs for your USMLE that are going to have a narrow therapeutic index? Well, lithium is going to be one of them. And remember that conditions such as congestive heart failure, conditions such as hypovolemia, conditions such as diuretic use are going to cause you to have that decreased clearance of lithium in the kidney because you have decreased glomerular perfusion, and thus you are unable to pee out that lithium, and your serum lithium levels are going to go up. And that's why you're going to end up having more a predilection to go over here, the toxic effects. Warfarin, remember that is going to inhibit your vitamin K dependent clotting factors. Digoxin, which is going to inhibit secondary active transport. We use this in heart failure. Watch for the vision changes and the non-specific GI symptoms for digoxin toxicity. And then theophylline. Theophylline we use for asthma. And remember, it's a phosphodiesterase inhibitor. It increases cyclic AMP, and thus you get bronchodilation. But what ends up happening is you get toxic effects that are similar to you just drinking a lot of coffee. So when we think about bipolar disorder, you can integrate this sort of vignette. A CEO presents with sleep issues. As you can see, over the past 2 years, he has felt unmotivated and has filed for bankruptcy twice as he's made really poor purchases. He is sad and states that he has only slept 4 to 5 hours at night for many, many months, and it is challenging to focus at work. What do you think is the likely diagnosis here? Well, in this scenario, long-term bipolar, that is going to be known as cyclothymia. Cyclothymia is going to be kind of like dysthymia for depression. Understanding that cyclothymia is going to have symptoms for 2 years, and they're never going to be absent for greater than 2 months. So a nice mnemonic for you to keep in mind is that long-term depression is related to dysthymia, whereas long-term bipolar is related to cyclothymia. All right, so that was your mood disorders. Let's go ahead and go through psychotic disorders. But before we go on, I want to ask each and every one of you, are you guys learning and are you guys pumped to keep going on? Go ahead and type in yes into the chat box if that's true. All right, Surya, Jasmine, Simone, Davish, Miriam, Samrat, Elena, thank you guys so much for staying active and engaged. Let's go ahead and go through psychotic disorders next. Now, what I want to really focus on is really teasing out the different types of schizo diagnoses on the USMLE. Remember that you have schizoid and schizotypal. Those are going to be classically your personality disorders, whereas you have schizophrenia, schizophreniform, schizoaffective, and those are truly going to be your psychotic disorders. So I don't want you to get confused. We're going to break this down, and let's start a little bit with the personality disorders, schizoid and schizotypal. Now, schizoid patients are going to be your characteristic loners. They're going to have really no interest in relationships, and they're really happy with that. And that's a stark contrast for your USMLE vignettes of patients who have avoidant personality disorder. Remember, patients who have avoidant personality disorder, they can be alone, but guess what? They really crave relationships. They're anxious because of persecutory thoughts. They're like, oh man, what are they going to think of me? And so avoidant patients and schizoid patients are both going to be loners. However, schizoid patients are okay with being loners and by themselves. They're seclusive to themselves. And you can think of it as a toll booth operator at night on their lonely freeway. Contrast that with schizotypal, and schizotypal patients are going to have eccentric, magical thinking. they are going to have not too much functional decline, but they're going to just be in their basements and wearing wizard hats, and they're going to have these aloof, odd beliefs and dress. Understand that patients with schizotypal are going to have an increased propensity to develop psychotic symptoms later on in life. So when you think about personality disorders, one of the key elements that I need to stress is that personality disorders are what we call egosyntonic. That means that patients don't recognize that they have a problem. It's part of their personality. It's pervasive throughout all elements of their life, and that is egosyntonic. The next thing that we're going to be doing is really teasing out the other schizo diagnoses, and that's related to psychosis. Now, remember that psychosis is going to kind of be a triad of a few things. Psychosis is going to be best illustrated by this multiple choice question, and then we'll go into the triad. A 30-year-old male is found at a park urinating in a fountain. He states that he must hide from the CIA as they know of his radioactive lab. He used to live with his girlfriend, but over the past year, he lives on his friend's couch. He broke up with his girlfriend and he quit his job. See the functional decline right here? When questioned, he has a flat affect and says, "I don't care." What is the likely diagnosis? So here, you notice that he's had symptoms for quite some time. And so when he's had symptoms for quite some time, and you notice this disorganization, these hallucinations, you're going to be thinking of schizophrenia. And look at that time period that is snuck into this question over the past year. So the triad for psychosis, you think about delusions, which are fixed false beliefs, disorganized thought, which is essentially this activities of daily living decline in both thought and behavior. So watch out for, oh, they're not speaking as well, or maybe they're not taking care of themselves from a hygiene standpoint. And then finally, you're going to be thinking about hallucinations. And remember that hallucinations are false sensory perceptions with stimuli that are not even there. That's different than an illusion. An illusion is like, oh, there's a stimuli, but I'm misinterpreting it. Whereas a hallucination is that, hey, there's not even a stimuli and I have some element of sensory perception. So what I want you guys to recognize is that timing is everything. Remember, brief psychotic disorder is anywhere from 0 to 1 month. And what we have to recognize with brief psychotic disorder is that it usually ends up resolving on its own. You have schizophreniform disorder. That is schizophrenia symptoms that is lasting 1 to 6 months. Then you have schizophrenia or schizophrenia that lasts greater than 6 months. And then you have schizoaffective disorder. And remember, we talked about the difference between schizoaffective disorder and mood disorder with psychotic symptoms. Remember, schizoaffective disorder, there are 2 weeks where you are just grossly psychotic. Let's go through this pharmacology question. A patient is newly diagnosed with psychosis. She is started on an antipsychotic. The patient is at follow-up 3 weeks later and states that she has been, quote, challenged to have sex because she just doesn't feel interested. Exam is notable for increased glandular nodularity of the breast with intermittent bilateral expulsion of white discharge from the breast. What is the likely pathway which is affected? Going into your neuroanatomy, arcuate fasciculus, nigrostriatal, mesolimbic, or tubuloinfundibular. And if you said tubuloinfundibular, you are absolutely correct. Remember that a lot of these psych agents are going to act on dopamine. The antipsychotics specifically are going to have anti-D2 effects. And so we need to understand that there are normal dopamine pathways that can be affected when you introduce D2 antagonism. So let's kind of go into this paradigm. Remember that there is the mesolimbic pathway that regulates behavior. This mesolimbic pathway is going to be implicated in schizophrenia, psychosis. These are where our antipsychotics want to work, right? Your dopamine antagonism. You have your nigrostriatal pathway, in which you are going to have the clinical correlate of Parkinson's, Wilson's disease, Lewy body. Remember that the nigrostriatal, especially the D1 pathway, is going to direct movements such that if you have dopamine antagonism, you are going to have some element of Parkinsonism. And then you have the tubuloinfundibular, which this question was really highlighting. And that is going through how dopamine physiologically inhibits prolactin, such that if you take away that physiologic inhibition, prolactin levels go up. And that is that USMLE correlate of, oh, you have a patient who is on an antipsychotic and bam, they have milky nipple discharge or low libido. And that's because these prolactin levels end up rising with that antagonism. Now, there's a GI pharmacology agent that is really important for us to know that has anti-dopaminergic effects, and that is going to be metoclopramide. Metoclopramide can cause these kind of symptoms, especially the Parkinsonism features, and it can cause you to have dystonic reactions as well. So I do just kind of want to make a plug as we integrate pathophysiology with pharmacology, and that is this reverse pyramid approach, how I recommend students going through pharmacology for the USMLE. I like to teach the big class effect that we need to decrease dopamine. Remember that this is related to all your antipsychotics. We go through things like neuroleptic malignant syndrome and understand that the pathophysiology that we're trying to modulate here is psychosis. And you see this triad right here. My pharmacology course goes through a lot of the organ systems and the high yield pharmacology. And it's more of an integrative approach, both getting your sketchy concepts together as well as your pathoma concepts, kind of putting it together in one piece so you can have more of a dynamic active recall review. So if you're interested in that, go ahead and check it out. I wanted to really make a quick integration and a quick plug because I feel like it's been helping students to, or students have really found the pharmacology course to be very helpful in their preparation. All right, getting back to our review, let's go through this question. A 30-year-old male is found at a park urinating in a fountain, similar vignette. He states that he must hide from the CIA as they know of his radioactive lab. He used to live with his girlfriend, but over the past year, he broke up with her. Similar vignette, but now look at this. He is noted to have 10 psychiatric hospital admissions for depression and was discharged 2 weeks ago. He says that since he's been discharged, he doesn't feel depressed at all and wants to end the interview because the CIA will be here to kidnap him. What do you think is the most likely diagnosis here? So still you have these psychotic symptoms, but specifically, you notice that the patient has some mood symptoms, as you can see from his past psychiatric hospitalizations. But then, oh my gosh, since being discharged, he's had 2 weeks of only psychosis. And so as a result, this is going to be your schizoaffective disorder. As you can see, during this time, the psych hospitalization, he had mood symptoms, and maybe he had psychosis with it. But since he's been discharged over the past 2 weeks, look at this delusional behavior that he has, i.e. only psychosis. He does not feel depressed. And that is classic for schizoaffective disorder. And so what I want you guys to really do is pay attention to the details. And here is a nice summary table for us. First, what we need to understand is that you will have these diagnoses to tease out: schizoaffective depressed type, schizoaffective bipolar type. And remember, schizoaffective, 2 weeks of only psychotic symptoms. But you'll also have to contrast that with major depressive disorder with psychotic features and bipolar disorder with psychotic features. So as a review, remember that brief psychotic disorder, it's less than a month. 1 to 6 months, it's schizophreniform. Greater than 6 months, it's schizophrenia. And remember that there are active symptoms or positive symptoms that are early, and you could get negative symptoms like the flat affect, and then schizoaffective that has both mood symptoms and psychosis together. What I also want to highlight is this disorder, and that's known as delusional disorder. Now, in delusional disorder, you will have a vignette like this. A 25-year-old woman believes that she is an editor of a famous fashion magazine. She is irritated how she is unable to get employment, as she states that she is the best dressed at work. Her sister states that she works as a waitress and otherwise has no abnormalities on exam. So you notice that she's still going to work, but she has this kind of delusion, fixed false belief that she's a fashion magazine star. And so the time period for diagnosis for delusional disorder is greater than 1 month. And you have to recognize that there is only isolated delusions. There's no other hallucinations, and there's not much marked impairment as well. And sometimes couples can share the same delusion together. All right. That is going to be your psychosis review. Let's now go into eating disorders. We're almost done with this review. Thank you so much for staying active and engaged. Eating disorders, let's warm up with this question. A 17-year-old female is admitted to the hospital due to weight loss and syncope. An NG tube is placed and feeds are initiated. On day 2 of admission, the patient reports shortness of breath and has recurrent episodes of ventricular tachycardia. She has tachycardia and hypotension, and labs are notable for low phos, low mag, hypokalemia. Which of the following hormones best explains the patient's deterioration? A, T4, B, cortisol, C, aldosterone, D, insulin. And so this is a patient who has chronic malnutrition. You initiated feeds, and bam, you have these electrolyte disorders. The answer here is going to be insulin because you're worried about refeeding syndrome. And so with eating disorders, you always want to understand that once you initiate feeds, you got to monitor electrolytes very closely because of insulin's effect shifting electrolytes intracellularly. And thus, you can have cardiac abnormalities as well as signs of fluid overload and heart failure. So let's go through the pathophysiology of refeeding syndrome. Again, it's related to eating disorders. The big picture is that you have electrolyte shifts that cause end organ dysfunction. Remember that when patients are chronically malnourished due to decreased access, or even if they have restrictive behavior, they're going to go into a catabolic state. Once you initiate feeds, you have a sudden shift to anabolism, building things up. And so what hormone is important for that? Insulin. But if you don't monitor electrolytes or give supplementation, these patients can have a shift of phos intracellularly. Remember, because now they're like, oh gosh, my cells need to make ATP. You're going to have hypomagnesemia, hypokalemia as insulin pushes potassium into cells, and fluid retention, because now during nutritional rehab, you're getting a little bit more of solutes and solvents. And so what's high yield for us to recognize is that these patients can have cardiac arrhythmia, such as QT prolongation and VTAC. They can have neurological symptoms like ataxia, and they can even have seizures because of the electrolyte abnormalities. Very high yield for us to understand refeeding syndrome and the electrolyte abnormalities, because there's a nice endocrine integration right there. All right, so what we're going to be going through is the difference between anorexia and bulimia. Now, when you're thinking about anorexia, remember that these patients are going to have low BMI. I can't stress that enough. They're going to have this fear of weight gain. And remember that you can have binge and restricting type of anorexia. It's not just the restrictive behavior. They can have binge type behaviors such as laxative or diuretic abuse, as well as electrolyte abnormalities. And so this is extremely important for us to keep in mind here. And remember that these patients with low BMI, they're going to have secondary amenorrhea. So you may want to integrate that. They may have osteopenia, and they may have key physical exam findings such as lanugo, which is this thin hair that comes on top of them because of their low body weight, as well as if they have the binge type, they can have parotid gland swelling because they keep vomiting and releasing all of that salivary amylase. And then they can have these calluses as they're doing their binging type behavior. Now, patients with bulimia have relatively normal or slightly elevated BMI. The most common type that you will see is this binge eating disorder, where they have this compulsive behavior to counteract what they ate, and they'll have self-induced vomiting. So I can't help myself but integrate the fact that the BMI will be seen in the vital signs in your USMLE vignettes. Do you see how the strategy element is really important? So now for eating disorders, you're really going to pay attention to all the vital signs and especially the BMI number. I also wanted to integrate acid base. And remember that if you have chronic vomiting, you are going to get a metabolic alkalosis, as you are going to be throwing up all of the HCl. And so on your blood gas, you're going to have a high pH with a high bicarb. And remember, with diarrhea, say that you have chronic laxative abuse, you're going to have a metabolic acidosis. And so metabolic acidosis, as you're losing potassium and bicarb, is going to be characteristic of a low pH, a low bicarb, and typically these patients with diarrhea are going to have a non-anion gap metabolic acidosis. Also understand that you can have a contraction alkalosis if you are going to chronically take diuretics like furosemide for your binge type behavior. Moving on, a 40-year-old man was recently started on a medication for depression. 6 weeks later, he has been having issues with erectile dysfunction. He is considering stopping the medication due to this erectile dysfunction and requests alternative treatment. What is the most appropriate selection for this patient? A, trazodone, B, imipramine, C, citalopram, or D, bupropion. And so because this patient is having SSRI-induced erectile dysfunction, you want something with less side effects of sexual dysfunction, and that's going to be bupropion. But why did I put this in this portion of the review? Because remember, bupropion is going to be contraindicated in patients who have eating disorders because bupropion decreases the seizure threshold. And like we mentioned before, these patients with eating disorders may have some electrolyte imbalances that already make them at risk to have a lower seizure threshold. And so a medication like bupropion is going to decrease the seizure threshold. And now let's go ahead and integrate all of the medications for your USMLE, which can decrease the seizure threshold. Are you guys having fun? Go ahead and type in yes into the chat box. This is live integrative review. I hope you guys are learning a lot. Grippa, thanks so much for being so interactive. David, Neha, Simone. Let's go through all of these medications that decrease seizure threshold. First one, isoniazid. Isoniazid, remember, mechanism of action. It impairs mycolic acid synthesis, and you get this characteristic vitamin B6 deficiency, so you have to give pyridoxine with these patients. Remember that bupropion is a what? Norepinephrine dopamine reuptake inhibitor. Imipenem and cilastatin, that is going to be a penicillin-like derivative, and it is going to inactivate penicillin binding protein, causing cell wall lysis. It's an antibiotic. We pair it sometimes with cilastatin because cilastatin decreases imipenem inactivation in the renal tubules. And that's really, really important for us to know that imipenem can be inactivated by DHT1 in the renal tubules, and cilastatin makes imipenem last more. And then finally, what is going to be a medication which acts as a weak opioid, increases serotonin and norepinephrine, but also decreases the seizure threshold? That's going to be tramadol. And so tramadol we use for patients who have chronic pain. Our last section that we are going to be going through, ladies and gentlemen, is going to be the drugs of abuse. Let's go ahead and warm up with this question. A patient presents after being brought by his roommate for weird behavior. He was totally fine 2 days ago in class. His roommate noticed that he was yelling and constantly locking and unlocking the door last night. He is noted to have hypertension, tachycardia, and dilated pupils. His roommate states that the patient has also not slept well due to his exams. What is the likely diagnosis? A, substance-induced psychosis, B, delusional, C, brief psychotic, or D, adjustment with psychotic features. And many of you have picked up on this distinction, and that is that this patient has very somatic symptoms and it's going to be very acute. Look, hypertension, tachycardia, dilated pupils, you are going to be thinking with the acute onset of substance-induced psychosis. So let's kind of go through how I think about toxicology and these drugs of abuse. Now, I like to characterize for the USMLE these medications of abuse into uppers versus downers. Uppers, you're going to have revved up symptoms. Think about patients who are intoxicated with cocaine, caffeine, nicotine, PCP, LSD. They are really going to have vital signs that are going to be revved up, and they may even have hallucinations, delusions, etc. Patients who are going to be intoxicated with downers, you are going to be thinking of things like alcohol, opioids, benzodiazepines, inhalants, and cannabinoids like marijuana. So what's important for us to recognize is that downers, they're going to be really slow. They're going to have this sort of chilled out stigmata in the vignette. And so what's high yield for us to recognize is that many of these agents can cause like a toxidrome that has really salient features, like these defining characteristics, things like opioids. Remember the pinpoint pupils, rotatory nystagmus when you're thinking about PCP, or say that you are going to have somebody with inhalants. They may say there's a rash around the nose, or the nose hairs are going to be down, or red sclera that we think with cannabinoids. So whenever you think about drugs of abuse and these uppers and downers that we just introduced, you want to understand how patients are going to present with intoxication and withdrawal. So remember, uppers, you're going to be thinking like cocaine and amphetamines. With intoxication, they're going to be revved up. So watch for pupillary dilation, watch for hypertension. But if you have withdrawal from caffeine or withdrawal from cocaine, you're going to actually have downer-like symptoms. You're going to feel fatigued, tired. You're going to have headaches, right? So you're going to be pretty chilled out if you have withdrawal from an upper. Now, if you have intoxication from a downer, you're going to have downer-like symptoms. Slow rate, pinpoint pupils. Whereas if you have withdrawal from a downer, say you have withdrawal from opioids, you're going to have violent yawning. You're going to be revved up. For example, with alcoholism, you're going to have hallucination. Whoa. So withdrawal from a downer gives you upper symptoms. Do you see this distinction? So here's my test taking strategy for you guys. And that is that on the USMLE, always look for vital signs and pupils, such that if you have hypertension, maybe you have intoxication from an upper, or you have withdrawal from a downer. Also look at the pupillary changes, because that can clue you in as to if you're dealing with the upper and downer, and then stratify intoxication versus withdrawal. So let's go through some specific USMLE vignettes. A patient who is crying, has slurred speech, blacks out, and has wrist drop. The AST is greater than ALT. What are you worried about here? Well, you're worried about alcohol intoxication. And that wrist drop, I do want to give you that Saturday night palsy, in which the radial nerve is going to cause you to have that wrist drop because you lose your extensors. A patient with history of cirrhosis undergoes a gastric bypass surgery. On day 2 of hospitalization, the patient states that he is seeing the nurses have funny hats and sees bugs on the walls. Do you see these revved up symptoms? And because he doesn't have access to alcohol, you're going to be thinking about alcohol withdrawal. So the question reads, what is the most severe complication of this diagnosis? And that is going to be delirium tremens. Remember, delirium tremens, you have alcohol withdrawal symptoms, right? The alcohol withdrawal can cause delirium tremens, and this is fatal. You get confusion, agitation, fever, tachycardia. You want to recognize this quickly and give benzodiazepines, because of all the withdrawals, delirium tremens is deadly. All right, very good. So let's go ahead and shift gears and talk about this classic USMLE vignette. A homeless male with respiratory depression, pupillary constriction, decreased GI motility and constipation, and is 85% on room air, his pulse ox. So what is the cause of the hypoxemia? This is actually really interesting here. And that is hypoventilation. Remember, opioid toxicity causes you to hypoventilate. You're going to have single-digit respiratory rate in your USMLE question. And that has a nice pulmonary integration, because what happens when you have a decreased respiratory rate, you have an increase in P big A CO2 that outweighs your P big A O2, and thus you have less O2 that goes into your blood, and that's why you have hypoxemia, very high yield. This hypoxemia, guys, respiratory integration does not increase your AA gradient. Let's go ahead and keep moving forward with this contrasted vignette. Violet yawning, increased secretions. That's going to be characteristic of opioid withdrawal. Even think about lacrimation as one of the key features in your vignette. So what is the likely antidote for opioid intoxication? Well, go back to the mechanism of action. Remember, mu agonism is going to cause you to have all of these symptoms of opioid intoxication. So you want a mu antagonist, and that is going to be Narcan or naloxone. Let's pivot and go through this question. A 40-year-old female presents to the ED with a fracture. She states that she ran into a car in the parking lot because she has, quote, superhuman strength. She is hypertensive and tachycardic. She's revved up. Her exam is notable for vertical nystagmus, and she says, I'm not giving a urine on exam. What is the likely MOA of the drug of abuse seen in this patient? A, mu agonism, B, NMDA antagonism, C, GABA activation, or D, D2 antagonism. And people are putting in the answer, and that is PCP related. Remember, NMDA antagonism. Hey, guess what? What else is an NMDA antagonist that we use in anesthesia? Ketamine. Ketamine has similar properties. And remember, we use that as a dissociative anesthetic for like fracture reductions. Let's do this vignette. We're almost done. At a high school health fair, a nurse notices strange behavior in a 16-year-old male. She notices that he seems slow. And when she asks his name, he giggles and says, ha, where's the vending machine? His urine tox is pending. Which of the following features may be most seen in this patient? A, conjunctival injection, B, nasal perforations, C, meiosis, or D, bradycardia. And this patient is likely going to have marijuana intoxication, so you're worried about that conjunctival or scleral injection. So understanding the drugs of abuse, again, going back to this reverse pyramid, you got to understand whether we're dealing with the upper or downer. You got to integrate the mechanism of action, the specific name of the upper or downer, and the withdrawal or intoxication. Remember, you're going to correlate the mechanism of action, especially with vital signs, pupillary changes, as well as these salient features. And let's go through those salient features of these drugs of abuse. So opioids, key things for intoxication: meiosis, low respiratory rate. Remember, you'll get a respiratory acidosis because of hypercapnia. Cocaine, especially for your intoxication, grandiosity and agitation. Cannabinoids, you can get conjunctival injection and paranoia with your intoxication. LSD, you get these flashbacks, right? And you're going to be revved up. And PCP, you get this vertical or rotatory nystagmus. And so this is a scleral injection that I wanted to show you for cannabinoids. All right. So I do want to let you know that I posted one of my very first YouTube videos long time ago on antidotes and toxins. Essentially, what are the reversal agents? We went through opioid and we talked about naloxone. But I want you to know benzodiazepines, flumazenil. So I go through this in my toxin and antidote videos. I'm going to send you an email at the end of this session that has this link. But I do want to let you know that if you just go to YouTube and you type in HyGuru antidotes, that's the first video that'll pop up. And I want you to watch this as homework right after this session. I promise you, it'll give you great value. We go through cyanide toxicity, methemoglobinemia, etc. And so I want to close by summarizing some key points today, guys. And that is that in psychiatry questions for your USMLE, we got to know timing and isolating functional impairment. We also want to understand, especially for toxicology, those vital sign changes. And with psychiatric manifestations, you want to think about underlying medical causes. I really appreciate you joining in. If you love this active recall and integration, I want to spend just a few minutes highlighting some resources which will really help you for your USMLE preparation. I have a very unique rapid review and test taking strategy USMLE Step 1 course. This is the only course that really gives you a private tutoring-like experience right in the comfort of your study space. And I go through the highest yield topics from the rapid review of first aid to pathoma chapters 1 through 3. I even go through an integrative biochemistry active recall PowerPoint. And there are Anki decks that are going to be helpful for that space repetition if you're interested. So check that out. That's at HyGuru.com. And if you're going to also be interested in reviewing pharmacology, I mentioned my pharmacology rapid review course. And then finally, if you would like a whole host of resources that I have, not only will you get the test taking strategies, not only will you get foundations of pharmacology, but you'll also get a study schedule if you purchase the bundle. And the study schedule is actually so unique because it's on Notion. And I go through in a series of videos, not only some medical drills, but also I go through how do I review a UWorld block? How do you create a study schedule? How do you stay productive every single day? And so I want you guys to really check out my bundle course as well as my rapid review course. And if you buy the bundle course, I do have the option for doing a free one-on-one tutoring with you, 1 hour via Zoom. We'll go through test taking strategy, answer any questions you have. That is my thank you to those of you who really invest your time, energy, resources into preparing with me. I want to make sure I give you value. So I will be in touch to schedule that one-on-one review when you purchase the course bundle. Coming soon, I'm so pumped. I'm writing my own book covering all of the NBME top concepts. It's actually going to be an interactive book that will be mailed directly to you or on PDF that you can use as you go with my videos. And this is the NBME Top Concepts USMLE Step 1 book. It's kind of the new first aid. I'm gonna say it like that because I've really put a lot of work into this. So it is coming soon. It is going to be correlated to all of these NBME Top Concepts reviews so that you can prepare in an organized way. I'm so passionate about helping each and every one of you. And I just want to say a big thank you. Before you guys leave, if you don't mind, make sure you connect with me. Make sure you tag me on Instagram, blow HyGuru up on Reddit, YouTube, Facebook. Tell me what I can do to help you in your preparation and tag me because I want to go student by student by student, focusing on impact more than anything. Before you leave, type in one thing that you learned today. I'd love to answer any questions which you have. I'm going to stay for a live Q&A. But before you leave, please, 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 please type in one thing you learned, and then we can get on to questions. Thank you guys so much. All right. We have refeeding syndrome,